than the Safe Stations program in Arundel County. So I'm happy to bring up Jen. Hand the microphone over to you. Welcome.
Thank you. Good morning. Thank you. So this is going to be, again, just like Tyrone said, really hard to do because there's a lot of components to it. So I'm going to really just focus on a lot of questions I've gotten since we started and focus on just the program with a little bit at the end on the success, but more of how we got to where we are and how we're organizing what we're doing. Safe Station started April 20th of this year. Yes, April 20th, it was actually suggested to do it on Marijuana Day, for a purpose. So for anybody who didn't know what 420 is, look it up. But what is so impressive about this is this all happened in about a 6-week period of time. This was all put together. This is where you do things because we were in a crisis. Numbers were skyrocketing for us. We are the third highest, I believe, in overdoses still in Anne Arundel County. And so we had began an initiative earlier to do, as everybody was talking about earlier, about following up on overdoses, which we still do. But there was something that we were researching at the time that we were doing these overdose follow-ups offering treatment called PARI. And that is your Police-Assisted Addiction and Recovery Initiative. And we were seeing some success, like I said, on our follow-up, but the problem was we were going to them, and I really believe we were asking them to be ready when they weren't necessarily ready for treatment. And we, like I said, had been researching PARI, which is more of the individual who's suffering can come to a police station for help out of Gloucester, Massachusetts, and get the help that they need. Well, at the same time, Police Chief and I were talking about this. Fire was talking about another type of program called the Angel Program. So finally, I guess the fire chief and the police chief were talking, and eventually I got a text one night that said, "Do you really think this could work? If we opened up our doors," from the police chief, "do you really think this could work?" And my text back was, "Can it hurt?" I mean, really, we were losing people quickly. Our overdoses were going up. Why not try it? And when people call me and ask me, what do I think is the critical piece to making Safe Stations work, it really is the program I'm a part of, which is Crisis Response. I am the director of Anne Arundel County Crisis Response. That was a program that's already been in place since '99 with clinicians who respond on police radio 24 hours a day for mental health calls, substance use calls. I really call it any social situation that's occurring. Having that in place kind of allows us to do this in a quicker time frame, to be honest, because we are funded. I already had the staff. I was already 24 hours a day. I have a warm line that operates 24 hours a day. I have mobile clinicians. I'm already on police radio. So what happened is we all got together March 6th, health department, police, fire, from the county and Annapolis City, state's attorney, all got together and said, what can we do? And we said, let's try this. Let's open up all fire stations in the entire county, every single one of them, and our 4 police districts, 24 hours a day for anyone who's suffering from addiction. And so we did. So we launched that on 4/20. And basically how it happens is an individual wanting help arrives at a fire station or police station, says they want help. Immediately as they walk through the door, while they're assessing them, someone from fire or police calls directly into the warm line and dispatches out a clinician or a team to that fire or police location. While we're en route, fire is assessing them, making sure that they're not in acute withdrawal where they have to go to the ER. If they have to go to the ER, we are rerouted to the ER. We still meet them wherever they end up. If it's the fire station or the ER, it does not matter. We arrive on scene, we do an assessment, and I'll get into that in a little bit. Once the assessment is done, we then kind of take them to that next step or that next process depending on the outcome of the assessment. Why does this work? This works because we can cover a large location because we have so many teams on. And what I will talk to you about in a little bit is kind of the positives and negatives of what we've had to encounter as we've launched this. But once the assessment is done, we then help transport or move that individual to the next step, whatever that might be. Why does it work? I love this picture. This is the day that we launched on 4/20. Multiple agencies have to be involved for this to work. And I think in any of these programs you listen to today, it's really about partnership. I always tell my team, it seems like we're out there getting a lot of the recognition, but really the recognition starts with the county exec, the police chief, the fire chief, the health officer, the state's attorney, because they're the ones that got together and said, we will break down every barrier that we see to make sure that people get the help they need. What are the barriers? The reason we launched this was because we were ending up originally, crisis response has a hospital diversion person who every day goes into our 2 ERs and meets with the staff and decides what emergency petitions, what people in their ER need help that maybe are going to walk out that door and not get the help they need. We also have someone in the jail each day kind of going over what people are coming through with low-level crime that are not being successful because they're not linked to the right resources. So we were already there. So the issue became, for my staff, was I can't get them in because of their legal issues. And so one of the things was to partner with the state's attorney and to have the state's attorney involved because when they have the legal issues, nobody's going to put them into a 28-day program if they've got court in 2 weeks. Nobody's going to come forward if they have a warrant because they don't want to go through that process and the ramifications of that warrant. So what we did in safe stations is we said, come in, and we will walk you through all of those processes no matter what the background is. Now, saying that, there are a few stipulations. If there are charges, on the severe side, we cannot do anything. But low-level warrants, violation of probation, those kinds of things, we will work with probation on that piece. So what happens is they come into the safe station, we ask them about their charges, we ask them about that, we immediately get on with the state's attorney. The state's attorney has assigned someone to the state safe stations program. So 24 hours a day, if someone has an issue with the legal piece, we reach out, we call them, and they start that process for us. What does that look like? If someone has a warrant, our CIT team, our crisis intervention team, which is actually housed in our crisis response system, which is a special trained officer in a soft uniform paired with a clinician, those individuals that come to safe station have a warrant will then walk that person through the process down to the commissioner, down to get their charges. But then the state's attorney is allowing them to be released back into our care to get treatment first. And what happens from that piece is they will go to court, they will deal with their charges, but they will deal with it when they are sober and able to understand those charges. This is the key, and this is how I sold it as we've started to work into the judicial process. I asked the judges one day, would you rather have someone standing before you with charges in withdrawal who can't process what the charges are and doesn't really care, or would you like to have someone who's been sober for 28 to 60 days accepting their charges and understanding what those consequences are so that we can work with them during their recovery on that piece? And I will go into an example in a second of how that is becoming successful. One of the problems when we started this, if I'm being honest, is police and fire originally thought, well, everybody's going to just show up because they want to get out of their charges or they want to get out of their court date. Didn't happen. Honestly, what we saw was the reverse. People hitting rock bottom, coming in, and not getting charges until they were actually in treatment. And what do I mean by that? A lot of individuals pawn, steal. Sometimes it takes a while for those things to catch up to them. Some of them are in treatment or out of treatment now getting charges. So one of the things we had to look at is how do we address that? And part of that is in our long-term plan, which is helping them by going to court with them and explaining what they've done through their treatment process and continuing to support them. We provide transportation, and we kind of follow them on a long-term plan. When they come into a safe station, they get a care coordinator for the long term. They get referred to peer support. They have a peer support specialist with them through the health department. The really key piece to this is long-term follow-up. We launched this on 4/20, and we are still dealing with the person who came in 50 minutes after we launched, who's in recovery and still sober today. But we're still assisting that individual who has gone through treatment, gone through the recovery house program, and is now living on her own, working. But the problem is we have to continue to support them, and part of that is having that care coordinator who can touch base with them 6 months out, a year out, peer support specialists following them. Just real quick, walking through the process, we have had, as of last night, 373 assessments done since 4/20. We are looking right now at a 62% success rate in completing treatment. Not everybody goes into inpatient detox. Some of this is people coming in who work, who want an intensive outpatient, so we do link them to outpatient, to mental health services. Some of them come in with more severe mental health, which is why it's nice that our mobile crisis is there, because we can assess where they are with their mental health, because there is that co-occurring piece. We've had a 10% relapse. The next numbers we hope to look at a little bit further out is on that relapse, we have had people re-enter treatment and stay in our program. Part that I'm proud of on Safe Stations is when they do relapse, they're calling back in and they're asking for help again because they've developed that rapport, whether it's with the peer support specialist or with one of our care coordinators. And part of this, just the last piece, is the reason we launched this was because we were doing the follow-up after overdoses. Our CIT teams were going out on every overdose. And originally we were only seeing about a 10% engagement rate of people wanting treatment following their overdose. And that's when we said, maybe going out when they're not ready is not the key, but looking at Pari's model, which is they will walk through a safe door when they're ready for treatment. And when they come into that fire station or police station, they're coming in ready. They're the ones motivated. We have seen an interesting last piece. Family members who drag them in, because the family member wants it more than the individual, are the ones that are not following through. The ones that come through that door saying, I'm tired, I don't want to figure out where I'm going to get my next fix. I almost died last night and couldn't feel my legs move. I can't do this anymore. I don't want to die because of my use. Those are the people who are in that 62% success rate. And so a lot of times when family members bring them through and they're not ready, we do that engagement with the family to understand addiction. And we have a special form we give family members to get themselves help, support systems for that recovery piece. So I think the one thing I can say is that it's a learning process for us. We're still working out a lot of kinks ourselves. We weren't expecting our success rate to be what it was. In October, we had over 70 people come in. When we initially met March 6th, I said I could handle 5 a week. Our highest was last week. We had 6 come in one day. So it's more for us now. We're growing. We went from 30 a month to 55 a month to 60 a month to last month having 75, I believe it was. So right now for us, it's the growing pain of the needs that we're trying to figure out is how do we continue to cover the volume with what we have in place already. Thank you.
Thank you so much, Jen. So I know there's time for probably one question. I know there are probably many more questions, but you know how to get in touch with Jen and the Arundel Safe Stations program. It's in the packet. Time for about one more question. Whoever's hand I see first here. Yes, sir, in the back.
How do you handle the safety aspect for those employees at the stations? You have somebody who comes in for addiction issues and says, I'm tired of doing this, and basically empties out his pockets or refuses to empty out those pockets, right? Mm-hmm. And how does that employee at the other end deal with that safety issue? I would think that currently they would call the police, and the police would come out and pat them down, do that sort of stuff. But that's exactly what you're trying to avoid by
It's a great question. We've actually had it happen. So what happens when people come in with paraphernalia on them? We have CIT trained officers, so we always have our plainclothes officer on, but we also have CIT officers in every district. Yes, they are in uniform when they're on patrol, that will respond when that happens. And we don't necessarily just go right into the pat down. There's been a lot of training in this piece. Part of safe stations is if you come in with paraphernalia or drugs on you, you're not being charged. You're coming in for help. It will be taken over by the police department. It will be inventoried. It will be turned in, but they will not be charged if it's on them. It will be taken out. So patrol will come out along with a CIT officer and work with fire. We do search people. They get searched anyways. When they go from there straight into treatment, they would be searched anyways. And so we make that known. And so basically, a lot of times they're forthcoming, we found, and put it usually right on a table. We've had 2 instances where people have disposed of it in trash in the bathroom of the fire station. And so what we've done is we've gotten smart. Every time someone comes to the fire station and uses a restroom, we do have one of our officers or someone go in and check to make sure that nothing is left behind for the safety of fire. But we have had some of those instances already. And basically, if they come in willing to give it up, we're going to work with them. Because, again, we're not trying to arrest our way out of it. Our goal is to get them into treatment. So I hope that answers the question.
Perfect. Thank you. I know there are more questions. Email has been shared. We do have to keep moving along.